committee will come to order, and today we're going to discuss how to update and strengthen Medicare's guarantee of high-quality health benefits for the next generation of America's seniors. And we've got four individuals who, by any objective assessment, are real experts in chronic care. So we thank you. Let me have some brief introductions. We'll go right to your testimony. Dr. Amol Navathe is a practicing primary care physician, associate professor of health policy and medicine at the University of Pennsylvania. He's also vice chairman of MedPAC, the Medicare Payment Advisory Commission. Please go ahead with your remarks.
My name is Amol Navathe. I'm a general internist physician and a health economist. Before I begin my remarks, I would like to emphasize that my comments reflect solely my beliefs and not the opinions of any organization I'm affiliated with, including MedPAC, the University of Pennsylvania Health System, or Perelman School of Medicine. Today, I would like to highlight why the Medicare program needs to better address chronic disease care and why this cannot happen without changes to physician payment. As a practicing physician, I witnessed firsthand the challenges that Medicare beneficiaries face in getting optimal care for chronic conditions. Take, for example, my patient, Mr. L., a wonderful gentleman suffering from diabetes, heart failure, and kidney disease. Mr. L has to manage his chronic conditions on his own, spending an average of 2 hours a day coordinating his medications, traveling to clinics, and attending appointments. He is one of so many patients who would benefit from a more proactive, patient-centered model of care, a model that could have prevented his recent hospitalization for kidney failure. In reflecting upon Mr. L's situation, I would like to share 3 key points. First, chronic disease may be the single most important challenge affecting the Medicare program. More than 2/3 of the Medicare population has 2 or more chronic conditions. The 15% of beneficiaries with 6 or more chronic conditions cost Medicare more than 3 times the average. Second, dramatic fragmentation plagues chronic disease care. Medicare beneficiaries with chronic conditions see more than 5 physicians concurrently. My colleague Matt Press found that over just 3 months, it takes a PCP over 50 interactions. Let me say that again, 50 interactions with other clinicians and the patient to actively coordinate care for just one important clinical condition. It's pretty astounding how much time and effort this takes. What does this have to do with physician payment? That leads me to my third point. Unfortunately, the status quo fee-for-service system is a key factor in producing fragmentation. The focus isn't on producing more health, just on producing more health care. Each clinician has their head down, focused on doing more visits and procedures, while the critical task of coordinating care often gets overlooked. With good intentions, CMS has attempted to fill this gap by adding more billing codes. But reducing the important work of clinicians to a list of codes is a fraught task. The result is an administratively complex system of ticky-tack codes that are underused because the cost of billing them is itself unprofitable. For example, the administrative cost to bill for a visit is about $20. That's more than the $15 physicians get paid for a virtual check-in visit. I sometimes call this death from 1,000 codes. So what's the path forward? Addressing fragmentation will require a new way of delivering chronic disease care, which in turn will require substantial changes to physician payment. Simply adding more dollars to the current system won't be enough. Physician groups need to be able to invest in new capabilities, use technologies like telehealth when safe, efficient, and effective, and staff practices differently. A natural place to start is investing in primary care. One promising path is to provide PCPs with steady monthly payments per beneficiary in addition to certain fee-for-service payments. This would balance the goals of preserving access while enabling PCPs to practice more patient-centered care. An additional benefit would be unshackling PCPs from a system that requires billing for each and every task. Another promising approach is to continue expansion of alternative payment models, which place accountability for cost and quality outcomes onto providers. This will require continued support for the CMS Innovation Center. Alternative payment models can improve care for patients with both high and low burdens of chronic disease. A great example has been the accountable care organization model. However, alternative payment models still rely on the physician fee schedule, creating conflicting incentives for some physicians. This leads me to point out that CMS needs more tools to manage the fee-for-service program effectively. There are many factors to consider in improving physician payment, and no single entity has all the required expertise. This effort will benefit from the input of multidisciplinary experts who could be convened as an advisory panel to CMS. Ultimately, CMS needs the ability to catalyze a new care model, and that will require adapting the fee schedule to accommodate new approaches, such as for primary care. This will require action. Unlike in Medicare Advantage, where we have seen substantial innovation to meet beneficiary needs on a near real-time basis, traditional Medicare requires congressional action to stay up to date. Hence, CMS needs more tools and authorities to better address chronic disease among Medicare beneficiaries. Thank you.
Because I want to understand a bit more about these 50 interactions that you talked about as it related to one patient in a 3-month period. And I sense what you are talking about here, and I don't want to put words in your mouth, is that if this patient was taken care of in a different kind of way, that, for example, Medicare would pay every month a flat sum for this patient to a primary care doctor, that primary care doctor would coordinate things. Is that something resembling English in terms of what you're talking about here?
Thank you, Senator, for the question. So I think there's two aspects. I think the first part is some of those 50 interactions, probably the majority, honestly, would need to happen regardless. This is just a PCP, a primary care doctor, having to talk to a specialist, contact the patient, make sure that everything is translated and coordinated and the patient is getting the right care. The second point that you're making is absolutely right. Some portion of those interactions would probably not need to happen in a type of payment model that you're suggesting, because the primary care practice would be able to staff nurse practitioners and physician's assistants and pharmacists and change the way that it's caring for that patient in a more effective and efficient way.
So have you made a list of these interactions in terms of, say, 2 or 3 different patients? I assume not in every case is there 50 interactions, but there'd be different numbers and you'd see different people and that sort of thing. But have you made a list that would be sort of a representative model? I mean, as you know, physician payment is discussed around here like the weather. Everybody says physician payment, oh my goodness, we've got to change it. It's not doing what we need to do. We're not spending the money effectively. We're not getting providers for this particular field and that. So I like your idea very much, because we have been looking, I see my colleagues, particularly Senator Stabenow in our White House, who specialize in this. We've been talking about what to do about traditional Medicare for ages and ages. And in fact, the legendary New York Times journalist, Robert Pear, who was the most authoritative reporter on healthcare, he did his last article on chronic care and our bill, and he'd been covering it forever. And we all walked away saying, we got to do more for traditional Medicare. And so we're going to want to get more details from you about how to do that with your idea of the per month, per patient kind of payment for coordination.